Good evening. My name is Chase Rend. I'm the Executive Director here at the National Building Museum, and it's my great pleasure to welcome you all for this evening's terrific program. As many of you know, the National Building Museum exists to advance the quality of the built environment by educating the public about its impact on people's lives. Through our innovative family, youth, and outreach programs, our wonderful public programs like tonight, and our exhibitions, the museum discusses issues related to architecture, landscape architecture, engineering, and design. Chief among those issues is sustainability, and the museum is proud to provide a forum for dialogue on this critical and very timely topic. Tonight's program is a continuation of our series, Sustainable Communities. This series expands on the topics addressed in our exhibition, Green Community, which I hope you've all seen upstairs on the second floor, from protecting our watersheds to innovations in green technology. The series continues in May with a program focusing on senior populations aging in place. We are very grateful to United Technologies for making this series possible through their generous support. And here to say a few words from UTC is Ken Langer, who is president of EMSI, which is a green building consulting firm that was acquired by UTC just a year or so ago. Ken? Thank you.
Well, welcome everybody. I have some notes here. First of all, let me say that we are really pleased, and UTC is very pleased to sponsor this event, and very proud to be working with the museum. A relationship which I believe began all the way back in the year 2000 when UTC and Otis partnered to develop the exhibit, let's see if I get this right, Up, Down, and Across, elevators, escalators, and moving sidewalks, which then I guess went on tour, so I guess the exhibit lived up to its name. Tonight we're going to hear from a preeminent scientist, Dr. Howard Frumkin, about how the built environment affects our health. This is the other side of climate change, and it really affects all of us, whether we're living here in Washington or in the West Indies. And as you may, so it's something that is not remote, and we'll come back to that. You may not know that UTC is a Fortune 50 company. You may not know that it's one of the 30 companies that makes up the Dow Jones Industrial Average, which went up today, by the way. You may even not know about UTC Fire and Security or UTC Power. I hope you do. But I'll bet you've heard of Otis Elevators. I'll bet you've heard of Carrier. And these are just two of the many companies that are in the UTC family. But and in fact, the UTC, when we put all this together, is the largest supplier of building equipment in the world. I repeat, the largest supplier of that really is an incredible thing, even for me, who's joined the company a year ago. But it's not enough for us to be the largest supplier of building equipment. We have to be the largest supplier of high-performance equipment. That's the stuff that actually brings down greenhouse gas emissions. That's the stuff that increases productivity. And that's the stuff that helps us be comfortable and improves our health, as we'll hear about tonight. So you know a little bit about Otis, I'm sure, but you may not know that the elevators today, because of their regenerative capacity, are 75% more efficient than they were 10 years ago. Or that the air conditioners, Carrier's air conditioners, require 20% less space, 30% less weight, and use 40% less refrigerant than earlier models. One of the most sort of striking of our technologies is with UTC Power, which makes fuel cells. And it's actually true that these fuel cells today are powering buses in North America and in Europe with absolutely no emissions, no noise, no emissions, and totally quiet. I just came back from India. I wish they had those in India. I think you can even drink the water, the byproduct of those buses. It's so pure. But we don't even stop at high-performance equipment. UTC now offers its clients a full suite of sustainable strategies and environmental solutions, including green building strategies, our company, energy audits, building commissioning, monitoring and verification, green building certification, and even financing through performance contracting. So we're the kind of company that's now using natural ventilation, that's using daylighting, and these kinds of strategies to first reduce the energy demand before we go putting in equipment. I went to a talk soon after I was acquired by UTC, and I got up there and I said, the first thing I said was, I want to sell you less air conditioning. And the guys who brought me in, who were all Carrier, I could see their faces drop. But I went on to explain that this is really the future, and we're doing it, and I think by working that way, we get a lot more customer loyalty. Our own company is a good example. We've brought green building strategies to 11 countries and almost 200 projects. And one example is the Beijing Olympic Games, where we worked with the developer of the Beijing Olympic Village and got the whole village certified under the new LEED for Neighborhood Development certification. So I guess the point is that there is a big challenge to be met today. With climate change, with health, with cities growing, but as we all know, every challenge brings opportunities, and I believe that we at UTC are really on top of it. So finally, I just want to end by saying how happy I am to say also that UTC practices what it preaches. Between 1997 and 2008, UTC reduced its energy use by 22% and its water use by 50%, while at the same time doubling the size of the company. So you can see that these kinds of improvements, though difficult, are really possible with a strong commitment. Our sponsorship of this series comes through the UTC Sustainable Cities Grant, which has worked with, partnered to support the development and use of green building practices in urban centers through the National Trust for Historic Preservation, the Habitat for Humanity in New York, and others. And it creates new programs, too, like the Green Build 365 learning portal that now tens of thousands of people are building professionals, architects, engineers are using. You get that through the USGBC website. So all of this to say that we believe that UTC is not just a proud sponsor of this program, but we'd like to also think that we're a proud partner in this whole effort to have a more sustainable world. Thanks for the opportunity to say a few words.
Thank you, Ken. We're very proud of our partnership with UTC, and thank you for supporting this series. And now, you all are in for a real treat. I'm very pleased to welcome back to the museum tonight's speaker. And as you can see by his title, his business card is about this big. Dr. Frumkin is one of these extremely accomplished people. He is an internist, environmental and occupational medicine specialist, and an epidemiologist. Before joining the CDC in September of 2005, Dr. Frumkin was professor and chair of the Department of Environmental and Occupational Health at Emory University's Rollins School of Public Health and professor of medicine at Emory Medical School. He founded and directed Emory's Environmental and Occupational Medicine Consultation Clinic and the Southeast Pediatric Environmental Health Specialty Unit. Very busy, and there's more. Currently serving on the Institute of Medicine Roundtable on Environmental Health Sciences, Research, and Medicine. Dr. Frumkin's interests include public health aspects of urban sprawl and the built environment, air pollution, metal and PCB toxicity, climate change, health benefits of contact with nature, and environmental and occupational health policy, especially regarding minority workers and communities, and those in developing nations. Dr. Frumkin was also an invaluable member of the advisory board to the museum's Green Community exhibition. He contributed a great deal of information and knowledge for us. So I hope you've all had a chance to see that show. It's here until October, so if you haven't seen it yet, you have a little bit of time. Dr. Frumkin is the author or co-author of over 160 scientific journal articles. And his books include Urban Sprawl and Public Health, Environmental Health from Global to Local, and Green Healthcare Institutions, Health, Environment, and Economics. He received his AB from Brown University, his MD from the University of Pennsylvania, his master and doctorate degrees of public health from Harvard, his internal medicine training at the hospital of the University of Pennsylvania and Cambridge Hospital, and his occupational medicine training at Harvard. Following Dr. Frumkin's lecture, we will open the floor to questions from you, the audience. And if you're not able to ask your question this evening, or if you wake up at 2 o'clock in the morning with a brilliant question that you hadn't thought of tonight, you can submit your questions to our online Q&A forum, which is found on our website, www.nbm.org. And about 2 weeks from tonight, we'll submit a selection of the questions that you have posed to Dr. Frumkin for his responses. So we will continue to keep him busy. And then we'll announce the answers or announce the fact that those answers are posted on our website with upcoming email notices to all of you. So, enough information, and now, please welcome Dr. Howard Frumkin.
Thank you very much, Chase, and thanks, Ken, wherever you got to. There you are. Hi. And good evening, everybody. Let me get to know you a little bit. This is a relatively small group. It feels like classrooms used to feel when I was a teacher. That is, it's small, and everybody assiduously avoids sitting in the front row. So this is very much like a classroom. How many of you are in the architecture field? A few. And your hands aren't going very high, but I know you're proud of being in the architecture field. You're just worried that the employment may not look so good these days. How many in design and planning? Lots of planners. How many in a healthcare profession? Just a few. Good. Well, I'm absolutely delighted to be here. This museum is a wonderful place. The leadership is spectacular, and the exhibits are terrific. But I'm especially glad to be here because this is really a chance for our two worlds to meet and talk and share our thinking. The world of building sciences writ large, architecture, planning, design, and the healthcare world. So those few of you who are from the healthcare side of things, help me out as I extend myself. I appear before all of the planners and architects and designers as kind of a supplicant and a potential partner. And I think we can work together to achieve shared goals very effectively. The premises of the talk tonight are the following. First, green communities are good. I think we would all agree on that. Healthy communities are good. And if we can achieve both, that's really good. But it's not automatic that you achieve both when you aim for both sets of goals. We need to avoid the fallacy of universal goodness, that just because it's good in one respect, it's good in other respects. There are some times when green isn't necessarily healthy and healthy isn't necessarily green. But if we can optimize both, then we're doing very well. That's the first premise. The second premise is that we really need good evidence to get it right. And I want to say something that is a little bit impertinent and not meant to be, but that is that I think that the orientation that we have had for years now in the health sciences, that is, you have to have evidence to support the things you say ought to be done, hasn't necessarily gotten over to the design, architecture, and planning worlds. You can say things as an architect or a planner, and if you say them with authority, people think that they're true, but you don't necessarily have to have an evidentiary base behind them. And there's actually quite an interesting sociologic difference between the faculties in planning schools and the faculties in medical schools. That is, you have to do research if you're on a medical school faculty, and you don't necessarily need to be an empirical researcher on a planning faculty. Now, push back if I'm wrong on that, but I think in general there's much less of a research tradition, much less of a requirement for an evidentiary base for claims on the building side than on the health sciences side. But I think we would all agree that if we can merge those two perspectives, especially with all the insights from the built environment world, we'll do very well. So let me give you a quick health perspective on the built environment, and then talk about this question of how we know what we know, how we accumulate evidence to guide the very best policy choices. Here is a panoramic picture of the built environment as we've built it in the last few decades since the Second World War. the vast expansion of cities over large geographic areas, the conversion of traditional land uses at the metropolitan edge from forest and farmland to residential uses, the move toward low-density use of land, so it's not unusual to see several acres per family instead of the traditional several families per acre that prevailed in cities and towns for so long. All of those land use changes in turn obligate transportation changes, requiring that we commit ungodly acts of civil engineering like the one you see here. But that's not enough, of course, to prevent this regular twice-a-day occurrence in every major American city and town, quaintly called rush hour, as if it lasts only an hour. Of course, it lasts much longer than that. Is anybody down from Baltimore today? One person. You'll recognize this, but just for those who may not know Baltimore, I'll orient you here. So here is the Northeast. This is the New York Beltway, formerly known as the state of New Jersey. And this is the Washington Beltway. Here's I-95, signifying 95 yards between the beltways. All of this is the artist's conception of the Baltimore Beltway in the year 2025, after it's been newly widened to 1,472 lanes. Now, I mention this because it's more than just a built environment observation. It's a human observation. You can see here in this car, the child says, "Mommy, when are we going to be home?" And Mommy says, "We spend 60 hours a week in our car, honey. This is our home." So these land use and transportation changes, which are companion sets of changes, very much have human implications. Coming down to the neighborhood scale, the relatively conventional loop and lollipop neighborhood configuration, which features low connectivity, meaning for those who aren't planners, this concept that to get from this point to this point, or from this point over to here, is not a straightforward proposition, since without the grid-like arrangements of streets, you may have a serpentine trail to trace to get from one point to the next. Low connectivity. Low land use mix, or single-use land use. Entire neighborhoods like this that may go on for considerable distances without a single store or school or workplace or church or library, so that any trip to get a newspaper or a quart of milk is a trip by car. That set of building practices has special poignancy when it comes to where we cite schools. This is the cover of Governing Magazine from a few years ago with a story called Education, the compulsion to build schools in the middle of nowhere. We tend to see school districts finding that 30 or 40 acre parcel of land way out at the edge and plopping a school down there so far away from where any child lives that no child for the useful life of that school will ever get to the school by foot or by bicycle. My favorite one is this. This is Hubbard Lake Elementary School in Hubbard Lake, Michigan, whose motto really is outstanding in its field. This is a school that is 7 miles from the nearest child's home. So it's as if we've tried very hard to engineer walking and bicycling out of our daily lives. That helps explain this trend. CDC data showing that the proportion of kids who walk and bike to school has fallen between 1969 and 2001 from fairly large numbers to fairly small numbers. How many of us in the audience walked or biked to elementary school? So a fair number of people. How many have children who walk or bike to elementary school? And I see 4 hands. One, a very enthusiastic. That counts as 2 hands. But now, that's not a fair study. The denominator is different between the two populations that we just surveyed. But there has been a very, very real trend, as demonstrated by data, of a decrease in what we call active transportation, getting kids to school actively. Coming down to the street scale, we can further explain those behavioral changes. We're building streets that look like this. They're designed to move traffic, and they are designed not for pedestrians. The absence of any pedestrian infrastructure seems to be endemic, even in cases, as you see here, where people are telling us with their feet that they do need to walk. People who may not be able to afford a car, or people who simply have a preference for walking, as you see here. When it comes to pedestrian infrastructure, you really could be forgiven if you reach the conclusion that there's a diabolical force bent on preventing anybody from ever walking anywhere in this country. We build sidewalks that look like this, no buffer between the pedestrian traffic and the car traffic, no shade to shade people, nothing interesting to look at along the sidewalk, so it's no wonder that you might not see people walking. Deferred maintenance hits home in pedestrian infrastructure as much as it does anywhere. Sidewalks like this that our municipalities allow to crumble. Clear signals that we send to would-be pedestrians about how much we value pedestrian infrastructure with installations like this. Acts that in medicalese are called sidewalkus interruptus. This is called dislocation. The worst collection of pedestrian infrastructure that you could possibly imagine. Crosswalks that lead nowhere. Why would anybody ever walk on a crosswalk like this? This is the entrance to a gated community. This is the fastest, once when we had a housing market not long ago, this was the fastest growing segment of the housing market in the country. And what you can see here is that it is very explicit that no pedestrians are allowed. You can't get here by foot. You have to get here by car. And finally, reaching down to the scale of how we travel daily errands, we have built a drive-through culture so that almost everything's accessible without getting out of your car. We have drive-through pharmacies, drive-through dry cleaners. Notice, by the way, that drive-through is always spelled T-H-R-U, because whoever's behind this understands that busy drivers have better things to do than deal with constructions like O-U-G-H, so it's always drive-through. Drive-through liquor establishments, drive-through bakeries, drive-through grocery stores, drive-through automobile service establishments, drive-through opportunities to buy fine food, drive-through opportunities to wash it down with coffee afterwards. Drive-through banking, this is perhaps the most thoughtful and far-reaching example of the drive-through culture, because if you look closely at the console of this ATM, the buttons have braille, so that even blind drivers are accommodated and don't have to get out of their car. Drive-through opportunities to drop your letters off, drive-through opportunities to pay your water bills, drive-through opportunities to enjoy nature, drive-through opportunities to get married. But if it doesn't work out, drive-through opportunities at the courthouse to make your child support payments. And speaking of life cycle events, we have apparently an increasing trend of drive-through funeral homes, what I call a break for the wake. In the healthcare sector, one that's near and dear to my heart, we are seeing more and more opportunities for drive-through healthcare services. Here's a drive-through flu clinic, drive-through blood pressure check, an artist's conception of drive-through dental services, with relatively minor modifications in car design, and we're redesigning cars as part of the stimulus package anyway. How about drive-through colonoscopy? We probably can get there. Well, this one, if anybody can explain this to me, I would appreciate the explanation. And this one needs no explanation at all, because there isn't one. Well, all of this, from the metropolitan scale to the sidewalk scale, would give you the idea that we are bent on engineering environments that deprive people of the opportunity to be physically active, as USA Today noted. But that's not the only way in which this sort of approach to the built environment may have impacts on health. Not only do we engineer physical activity out of daily routines, but the air pollution implications of consigning most travel to be motor vehicle travel are considerable. The major cause of death in young people in this country is traffic crashes. And all things being equal, less time spent in cars means a lower risk of traffic crashes, lower risk of death. The climate change contributions are an indirect but very significant part of the health impacts of this built environment strategy. About a third of greenhouse gas emissions relate to the transportation sector. If we could reduce the amount of transportation that we use through motor vehicles, that would reduce the amount of fossil fuels that are burned, and that would help address our climate change contributions. Climate change, in turn, is recognized now as being a very significant health challenge in a wide range of ways, from heat waves to severe weather events, to the spread of some infectious diseases, to worsening air pollution, to worsening allergies, to threats to the food supply. A wide range of ways in which climate change will threaten health, and certainly the built environment that we have created over recent decades contributes to that problem. Food choices. If we have environments that confront people, especially students in schools or people in less well-off neighborhoods, with unhealthy food choices, that is a set of environmental cues that isn't carved in stone, but it certainly sends signals about the kinds of food that are most available and that are then favored behaviorally. The heat island effect. If we build cities in ways that concentrate heat, cities do concentrate heat, but some cities much more than others, then the increasing frequency of heat waves we expect under climate change will more and more place people in those cities at risk. Mental health impacts of cities. A wide range of ways in which cities can be mental health promoting environments or can not be, from opportunities to meet and greet other people to the so-called third places or places of the heart, places where people get together to mix and mingle. Opportunities to avoid road rage. Road rage is an interesting phenomenon. I'll mention in passing. Very poorly studied epidemiologically, but we know that there is this phenomenon of people having impulse control problems, becoming violent, and attacking each other, sometimes with fatal consequences on roadways. Much less well recognized is the problem of sidewalk rage, because for the most part there is no sidewalk rage. We've got a transportation system that tends to piss us off, and a transportation system that's actually healthy and generally puts us in a good mood, and we've tended to build the first much more than the second. So a range of mental health impacts. And the concept of social capital, opportunities to meet, greet, mix, and mingle that can be structured into community design or can be forsaken, and we've too often not built those into recently developed communities. So a range of potential health impacts from our approach to the built environment. And now to get to the question at hand, the scientific approach to all of this, how do we actually know what's good for people's health, and how can we incorporate those evidentiary conclusions into the way we design and build environments? If I give you advice about taking an antihypertensive or getting your colonoscopy, you have every right to expect that the advice I give you is based on evidence. You have every right to expect that the evidence shows that the intervention is safe and efficacious. We don't have that level of solid evidence-based advice for many aspects of the built environment. And it's up to us together, those of you in the built environment world and those of us in the health world, to work together to get that evidence. Well, in general, what does research look like? This is Research 101. You all remember this from high school. You specify a hypothesis, and generally, in very simplified form, pardon the reductionism here, you hypothesize that A is associated with B, or if you can really draw a firm conclusion, A is a predictor of B. You have to figure out ways to measure A and B in reproducible, precise ways, because otherwise you'll never be able to quantify the association. You control for possible bias and confounders that might undermine your observed association between A and B. You study the association with your data, and you draw conclusions. The paradigm for this in the medical world is the randomized clinical trial, the RCT, and it's schematically shown for you here. You define a population of interest on whom you want to test a particular intervention, a particular kind of chemotherapy, a particular kind of surgery, whatever it may be. You define eligibility and recruit participants into the study. And those participants are then randomly assigned to one arm or the other arm of the study. Sometimes there can be more than two arms. One arm gets one treatment, one arm gets another treatment. Or in some cases, it's a placebo and a treatment. And then they're observed for their outcomes. The observation ideally should be double-blinded, meaning that neither the observers nor the participants know which arm of the study they're in. What's the reason for that?
Avoid bias.
You avoid bias, sure. If I know that I'm getting the new, possibly wondrous treatment and not the old treatment or the placebo, I may be more inclined to feel better and do well with that. That's the placebo effect, and that would bias the results, that would bias the conclusions one might draw about the impact of the treatment. So the double blinding is an important method to control bias. Why randomize? Why randomly assign people?
Regional effects of one population over another.
Good. So there may be regional effects or any of demographics. Exactly right. There can be lots of variables that come into play that would affect the way people respond to the treatment. To the extent you can, you'd like to distribute those variables equally across the two arms of the study so that you can conclude with some confidence that those other variables, called confounders, don't account for any differences that you see. At the end of the day, you'd like to attribute any differences you see to the treatment that you gave, because that's the variable of interest. Okay, we can't really do randomized clinical trials when it comes to the built environment. If I could randomly assign half of you to live in one neighborhood and half of you to live in another neighborhood and study how you did, who ends up more healthy 5 years down the road, that would be great, but we can't do that. But what we can do, and what we do, and what I'm going to try to show you in the next few minutes, is we look for experimental designs that replicate as closely as possible the virtues of the randomized clinical trial. This is where the creativity comes in. This is where we all need to be working together to figure out the ways to do these studies. So let me show you three general kinds of studies, give you a couple of examples of each as applied to the built environment. I'm going to ask you for your critical participation. This is a small enough group that we can talk with each other. First one, this is observational study, a very common kind of study, so common that I'm not even showing you a specific study. I'm going to show you the generic study. This has been done probably 50 to 100 times in the last decade. You have the hypothesis that walkable neighborhoods are associated with more walking. In fact, you may even take the hypothesis further, and you may say that walkable neighborhoods are associated with more walking, which is associated with lower blood pressure or lower weight gain or some other good outcomes, maybe even lower mortality if you have a long enough follow-up period. So you find a couple of neighborhoods, some are very walkable, some are not so walkable, and then you study the people in those two neighborhoods. And that has been done many times. Some of the studies are surveys where people are simply asked, how much do you walk, how much do you drive? Some of them are direct observational studies where GPS devices are put in people's cars or put on their belts, or pedometers are put on their belts, lots of ways to measure travel behavior. Almost universally, these studies show that in more walkable neighborhoods, people walk more. Therefore, conclusion, walkable neighborhoods predict more walking. What do you think? Are you convinced? Is this enough to go to your legislators and say we need to build more walkable neighborhoods as a method of health promotion?
There's self-selection. What are people that would walk more anyway choose the neighborhood?
Sure. Great observation, and exactly the shortcoming with these kinds of studies. Comment was there's self-selection. It's very likely that the walkers move to walkable neighborhoods, and the couch potatoes move to non-walkable neighborhoods because they're going to drive all the time anyway. So this is an example of a confounder. That is, there's another factor, an extraneous factor that interferes with our observed association between neighborhood design and walking, and that is the constitution of the people that we're studying. So this is an imperfect study design. It's a pretty far cry from that ideal randomized clinical trial and doesn't give us as strong a basis for drawing conclusions as we might like. Here's another observational study. This one just published last year. This is a very interesting study looking at the phenomenon of neighborhood greenness. The investigators hypothesized that greener neighborhoods would be better places for kids to grow up. They used satellite observations to be able to code the greenness of each of, I forget how many, dozens of neighborhoods in Indianapolis. They looked at 3,800 inner city children on whom they had weight gain data over 2 years and whose residences they were able to map to particular neighborhoods. So they could tell how green your neighborhood was and they could follow your weight gain over 2 years. They controlled for a number of potential confounders, age, race, sex, residential density, and they found out that the kids who lived in greener neighborhoods gained weight at a substantially slower rate than the kids who lived in less green neighborhoods. What do you think? Does this support the health recommendation that we should be planting trees in our neighborhoods? It'd be nice if it did. After all, that we like green communities. Did they control for income? Interesting. So maybe the greener neighborhoods are better off neighborhoods in some way. And maybe those better off qualities in those neighborhoods are actually the predictors of lower weight gain. Maybe the more barren, less green neighborhoods have more fast food restaurants in them. Did they control for the number of fast food outlets? Education. I think no, you're right, they didn't control for education. Good. So lots of potential confounders not controlled for. Interesting study, not very conclusive, and that's one of the flaws with these observational studies. Much of the evidence that we have about the health benefits of green communities comes from studies like these. So let's go to a second kind of study design and see if we like it any better. Natural experiments. These are great. We can't randomly assign people to different built environments most of the time, but sometimes social circumstances do that for us, and if we're alert to when that happens, we can study those situations. Let me show you 3 nice examples of natural experiments. The first is a series of studies done in the Robert Taylor homes in Chicago. The Robert Taylor homes, which are no longer standing, were a series of 28 high-rise public housing buildings that look like this along a 3-mile stretch. There's a relative island of low-income housing in Chicago, cut off on one side by a busy road, on the other side by railroad tracks. And it was one of the larger Chicago public housing venues for quite some time. When you got to live in Robert Taylor homes, you got there because your name rose to the top of the waiting list in the Chicago Housing Authority, and you were then assigned to the next available unit. Well, the natural experiment that was lurking here and that was brilliantly recognized by investigators at the University of Illinois was that some of the buildings have green environments. They look like this on the outside. Others of the buildings were barren on the outside like this. Interestingly, there's a history here. All of the buildings had trees planted outside initially at the time of construction, And some of the residents came to believe that the trees were hiding places for predators who were lurking, and so that it was actually the residents who took the trees down. But a number of the buildings did remain green and attractive like that. So the investigators looked at people who lived in the first few floors of the buildings where there was actually a relative visibility of the greenery, and they conducted survey research asking people in both kinds of buildings about various aspects of their lives. Random assignment to one building or the other, wherever there was vacancy. All of the other variables seemed controlled as nearly as they could determine. They asked people about social dynamics, about aggressive behavior, and found fascinating findings. You were much more likely to know your neighbors, greet your neighbors, help your neighbors, visit with your neighbors if you lived in a building where there were trees outside than if you lived in a building that was barren outside. You had substantially higher rates of violence in your life, violence that you had suffered and violence that you had committed if you lived in a barren building than if you lived in a building with trees outside. And the number, I'm not showing you the numbers here, but the numbers are dramatic. It's a shocking difference in levels of violence in the two kinds of buildings that could not be attributed by the investigators to anything but the level of greenery. There were no other apparent differences when they looked at demographics, age, education, other factors. So this was a natural experiment and a very persuasive one, suggesting a salutary role for trees outside buildings. The second, this is a classic study, and those of you who saw Roger Ulrich here last month may well remember this. This was a retrospective study over a 10-year period of all cholecystectomies, gallbladder removals, at one suburban hospital outside Philadelphia. The natural experiment here was this. When you finished getting your gallbladder out and you were taken back to the recovery room on the surgical floor, half the rooms had views of trees outside the window. The other half the rooms had views of a brick wall. And it was a random assignment which room you ended up in, depending on where there was an empty bed. So the investigators took a look at all of the records of cholecystectomies over a 10-year period, confining their observation to the spring, summer, fall season when the deciduous trees were in bloom. And what they found was that if you had a tree view room, you had a 1 day shorter hospitalization. This, by the way, I'll mention in passing, it's a dated study. This was from the days when you could actually be in the hospital for a week after having a gallbladder out, in contrast to the modern drive-through method. Less use of analgesic medications and fewer negative nursing notes in the chart, all by virtue of having a view of trees outside the window of the hospital. This is so much closer to a randomized controlled trial. Now, it wasn't blinded. People knew that there were trees outside the window, and that has to be reckoned with as a potential limitation to the study, unlikely to explain the findings here, suggesting quite strongly that a view of trees outside a healthcare establishment, and perhaps more generally, access to nature during and after healthcare encounters may be good for patients. A nice example of where what's healthy and what's green seem to coincide. Third example of a natural experiment recently published by Craig Zimring at Georgia Tech and his colleagues is a study of skip-stop elevators. Anybody know what a skip-stop elevator is? This is a relatively new concept. This is a strategy that has been tried as a means of promoting physical activity. You have elevators in your high-rise buildings that only stop at every third floor. And that means that if you want to get to the 6th floor, you're either going to ride to the 7th or the 10th, or the 5th, 4th, 4, 7, 10. It's tough to do this kind of thing on stage. And then you have to walk up or down the remaining 1 to 2 flights of stairs. So this is a means, I think I've delicately said this is designed to promote physical activity. It's actually designed to compel physical activity. And when this is done, it's not done in a very heavy-handed way. It's done in a more thoughtful way typically. So the elevators only stop at every third floor, but there is an attractive open staircase so that people have sort of a seductive quality, a pull factor to get them walking on the stairs. That's in contrast to the more typical clandestine, cinder block-laden staircases that typify so many buildings. There are always ADA-compliant elevators that stop at every floor that are provided, that are pass-key accessible for those who have need of those elevators, but everybody else has to use the stop or the skip-stop elevators. Well, the study that was just published took advantage of a natural experiment. This was at the Caltrans, that's the California Department of Transportation district office in LA. It's a 13-floor building. The building looks roughly like this. There were two, architects can help me out here. What do you call that column in the middle of the building where the elevators and other utility shafts are? It's a a shaft, okay? There are 2 shafts in the building. It's a quite large building with 1,700 employees, over 100 employees per floor. This shaft had installed in it the skip-stop elevators, along with this nice open skip-stop staircase, and the ADA-compliant elevator was left in place there. The other half of the building was left with its traditional shaft arrangement, and that was conventional elevators and traditional stairs that were unattractive, unappealing stairs. So the investigators were able to compare the experience in this half of the building with the experience in this half of the building. Which staircases do you think were used more? Well, what they found over a 6-month period of observation was that there were 117,000 uses of the skip-stop stairs, and there were 3,500 uses of the traditional stairs, a differential of about 33-fold. So they were able to conclude from this, and I think few of us would argue with this conclusion, that if you use the skip-stop stair arrangement, people use the stairs a lot more. You do generate physical activity. They also did some survey research alongside this study, and 73% of the employees reported that they used the stairs daily. They had mixed results in terms of the impacts on morale and on how much people liked it. Fair numbers of people liked using the stairs. They felt grateful that they were forced into it. But there were also substantial minorities that were unhappy with it. So it's not clear that attitudes changed across the board, but in the majority of people who were in the building, they were fine with it and even grateful for it. So here's a suggestion based on evidence that changing the ways that people move around buildings through architectural strategies can have an impact on physical activity and then on health. Let me tell you about one more study design, the before-after study. This is a form of natural experiment, although sometimes done in a very deliberate way, almost as if it were a planned experiment. This is a paper published in the Journal of the American Medical Association. It was published after the Olympic Games in Atlanta. In 1996, we conducted an experiment in Atlanta. We wanted to see what would happen if people drove less. What would the impacts be on air quality? Well, we knew that there was no way to get people to drive less in Atlanta unless we brought a very big party to town and threatened them with horrible traffic jams. So we brought the Olympics to town and then studied what happened. Now, the backdrop to this is the following. Atlanta is one of many cities around the country that suffers from high ozone levels. Ozone is an air pollutant. It doesn't come out of tailpipes and smokestacks. Rather, it forms in the air from precursors that do come out of tailpipes and smokestacks, oxides of nitrogen and hydrocarbons. Those precursors combine under the influence of heat and sunlight to form ozone. So the summer season is the ozone season. You remember I mentioning a few minutes ago that climate change is liable to worsen air quality, and one of the principal mechanisms there is that longer, hotter summertime seasons will drive the formation of ozone more than is currently the case. So in a typical summer day in Atlanta, we have 2 episodes of charging the local airshed with precursors of ozone. We begin with a low level of ozone in the morning. It's an unstable molecule that doesn't hang around for long. But here's the morning rush hour. We emit large quantities of oxides of nitrogen and hydrocarbons. Ozone levels begin to climb. Here's the afternoon rush hour. We further push that reaction. And by about the late afternoon dinner hour or so, ozone levels reach the unhealthy point. We care about that because ozone is a quite potent respiratory irritant, and it triggers attacks of asthma in children who suffer from that disease, triggers coughing and chest discomfort in many people, even people without asthma. So it's a real problem for public health in the cities that have ozone problems. That's why we cared about looking at the impact of changing transportation patterns on air quality and on health. So, during the couple of weeks of the Olympics, people in Atlanta were told, don't drive, take the bus. And they actually complied pretty well. Peak traffic levels declined by 23%. Peak ozone levels declined by 28%, as you can see here, down and then right back up to baseline when the Olympic Games were over. And what was striking was that during that interval, the incidence of acute asthma attacks among children dropped by as much as 44%. Depended on how you measured it. Was it emergency room visits, HMO visits, or whatever? But it dropped from 11 to 44%, substantial drops in the number of children who needed to seek medical attention for acute asthma attacks. Now, since you have become incisive epidemiologic thinkers in the last half hour, you're wondering, maybe that's just because people fled the city in general and there was nobody left around to suffer an asthma attack. Well, that wasn't the case. Over here you can see that the medical visits for other conditions like appendicitis and broken legs and so on, conditions not related to air quality, didn't change at all. So the population experience overall was stable, but a substantial decrease in the number of attacks for acute asthma among children, a direct demonstration that change in the transportation system brought immediate and important health benefits. That's a before study, because we went right back to baseline at the end. A second, and this was the title of this talk, and I'm finally going to get around to it as advertised, Atlantic Station. Atlantic Station is a 138-acre brownfield redevelopment in the center of Atlanta, one of the largest brownfield redevelopments in the country. It began as Atlantic Steel. This was a functioning steel mill, one of the largest urban steel mills in the country, until it closed just about a decade ago. It's a relatively recent closure. This is what it looked like, shown in black and white to heighten the drama of this industrial behemoth. A student at Georgia Tech, which is located just next door to Atlantic Steel, as a master's project, dreamed up the idea of redeveloping that entire property. And it was an incredible thing, but his plan was accepted. Atlantic Station was redeveloped as this mixed-use, live-work-play community right in the center of Atlanta. It's a very unusual configuration for Atlanta. Atlanta's a very sprawling city. So this is a much more traditional town-like place, not commonly seen in Atlanta. You can see that there is, something called the District here, which is a shopping area. The Commons, which is public open space, green space. Here is IKEA, a huge IKEA. This is where you can buy Swedish products all made in China, as opposed to American products all made in China. And there is a large residential section down here. It's an attractive-looking area. It's got a grid-like arrangement, which, as I said, is unusual in Atlanta. It's got public spaces and wide-open streets, as you see here. People do get out on the streets. You see organized activities. This is a stroller session where parents can bring their kids out and share the time strolling around. There are evening events, and there are just regular, informal, casual things. This sounds like second nature for those of you who live in Washington, but in Atlanta, this is really unusual stuff. So this was a brand new development. Lots of residential, forming what the new urbanists would call a transect, from relatively dense high-rise living to townhouses, as you see here, to single-family residences just a bit farther toward the edge of the development. And some public spaces, open spaces. This is actually a retention pond, but it's been made into a fairly attractive amenity in the middle. Well, the hypothesis that a group of researchers from Georgia Tech and Emory and the CDC came up with together was that something about living in this sort of development would be good for people's health. They would get more physically active. They would substitute what we call active transportation, walking, biking, and transit for their dependence on cars. And the notion here was the typical person moving into Atlantic Station within the metropolitan area was coming from a less pedestrian-friendly, more suburban setting on average into a denser, more new urbanist setting on average, and that change would be associated with behavioral changes and health changes. So, how would you study that kind of a hypothesis? Any ideas?
You'd have to study the same people before and after.
You would. And that would control for genetics and motivational factors and so on, right? The nice thing was that you were able to do that here because, and this really began before the housing market crashed, but about 3 years ago, when these units went on sale, they were snapped up like hotcakes. In fact, if you wanted to move into Atlantic Station, here's what you did. On the day when one particular phase of the residential units went on the market, you went down there with your $5,000 earnest money, and you put your money down, and the place hadn't even broken ground yet. But you had your reservation. And about a year later, when it was finally built, then you would move in. So that means that for about a year, somebody knew who you were and where you were, knew that you were going to be moving into Atlantic Station down the road. So you could be studied in your native habitat and then restudied after you had moved into Atlantic Station. And that allows us to do what Ken said correctly you would want to do. Now, if you were studied in June of the pre-move year and in June of the post-move year, keeping the seasons the same because physical activity patterns or travel patterns may vary with the seasons, there's a 1-year difference in your age, which is a relatively minor difference, and there's no difference in your genetics, in your social circles, in your motivational factors, or at least small differences in that regard. So this looked like a very nice opportunity to do a before-after study, and see whether people who moved from a relatively non-walkable neighborhood to this neighborhood would in fact change their travel behavior. It required a lot of measurement because you have to characterize the walkability of neighborhoods from which people are moving. And that meant entire techniques of characterizing walkability. It also meant measuring people's travel behavior before and after. So that meant putting pedometers and GPS units on them and tracking them for a sample of time, a week of time before they moved and a week of time after they moved. So that was the grand study design. And it's actually underway. We're funding 3 of these studies around the country, and they're on hold right now for the simple reason nobody's moving these days. The predicted rate of moving into Atlantic Station and similar developments elsewhere has dropped off enormously, so we can't actually finish this study and won't until we see an economic recovery. But it's an example of a research method that I wanted to call to your attention. So this just describes the study that I just described to you. To summarize...
Have you published the methodology for how you measure walkability, or is that
Yeah.
information that's available?
So that's been widely published, and the best place if you're interested in measures of neighborhood walkability is to go to a website called Active Living Research. And you can find it by Googling Active Living Research. It's a whole portfolio of research funded by the Robert Wood Johnson Foundation. And they are, as I am, they are enthusiastic proselytizers. And so on their website they've put all of the research literature relevant to this field of research. And that includes a methodologic section on how you characterize neighborhoods. Lots of ways to do it. You can use GPS methods to identify intersection frequency, which turns out to correlate well with walkability. In some jurisdictions, you actually have good data on sidewalk density, so miles of sidewalk per miles of street. And ideally, it's a 2-to-1 ratio. That means a sidewalk on both sides of every street. But few places actually get up to that. So there are methods like that for assessing neighborhood walkability, and an active debate in the literature about which is the best one, as you might expect.
In the Atlantic Station one, how do you control for the bias of people knowing that they're being measured in one place and then the other?
How do you control for the bias of people knowing that they're being measured? It's sort of a Hawthorne effect. The very fact that you're in there observing may influence their behavior. It's a great question. And the idea was that if you measure them for over a week, and you throw out the first day of observations, which is something that the investigators proposed to do, presumably their weekly patterns would they would go to work because they have to go to work, they would go on errands because they have to go on errands, and hopefully it wouldn't change very much. But you can never be sure that it doesn't change at all. So that would stand as a limitation of the study. I guess one of the conclusions here is that no study design is perfect. There is no such thing as perfect data. And that's one of the reasons, other than the usual love of doing research, that scientists say we need more research. Because if you can approach the same question in multiple ways, replicate findings in different fashions and different settings, then you have more confidence that your conclusions are right. But you're exactly right that people might vary their travel patterns based on the fact that they've got accoutrements on their belt and they know they're being watched. So there are lots of ways. I've only showed you 3 kinds of study designs, but lots of ways to gather data so that we can draw conclusions about what forms of built environment, from the building scale to the metropolitan scale, are good for health. To be able to characterize walkability, to be able to identify building features that may be promising, those recognitions really lie with those of you who are professionals in the built environment world. To bring the research methodology to frame the health questions to which we need answers, that's something those of us on the health side would bring. So this really is a need for us to think collaboratively. Whoops. There only are 2 buttons that I'm working on this thing. You would think that I would get straight which is which, but I haven't yet. We need to recognize research opportunities, and that really is a plea for those of you who do projects like this, coming from the health side. Every project that you do is a laboratory. Every project that you do offers an opportunity, at least potentially, to study it. Some people have gone so far as to call for setting aside 1% of every major development project for research. Because after all, we really do need to learn what works and what doesn't work. If we are advertising residential developments on the basis that they will make people or allow people to be more physically active, we need to know with some confidence that they actually do that. We are seeing residential developments advertised that way now, but we need a database to back up our conclusions. We need to fund the research opportunities. We are doing more and more of that at the CDC, at the NIH, which is really the larger research funder of the health agencies, more and more interest in this area as well. And private interests really need to step up to the plate and do some of the funding as well. And we need to collaborate in actually carrying out the research. So I finish with this sort of a proposal, if not a proposition. On the one side, health professionals, on the other side, professionals in architecture, design, and planning. And I close with the claim, and I hope you'll agree with me, that we would all benefit, and the public whom we ultimately all serve will benefit if we have good evidentiary foundations for recommendations about healthy places, and if we can show evidence that green places are also healthy places, so that we get to design strategies that both protect the environment and protect people's health. Well, thank you very much for your attention. I think we're early enough that we have plenty of time for discussion, and the kind of discussion that I'd really like to foment is this. Can you think of a project in which you've been involved that might have been a research opportunity from which you could have drawn conclusions about health? And how would that have gone? If we have a few case studies here in the room, that'd be very helpful to hear about those. But any questions or comments at all?
And we have a mic here, and we'd love to capture those questions for posterity, so if you could raise your hand.
Okay, I live in Montgomery County, and we have a development in the city of Rockville called King Farm. I believe it was a part of a 6 neighborhood study done by Health and Human Services in like 2004. I don't know, I haven't read the research on that, but I've been clued into that. The project is a fairly dense mixed-use development next to a metro station in a former farm. So that's a project that I know about. Maybe if you know anything about it, you could.
I don't know anything about HHS research at King Farm. I haven't heard of it before, but it's a fascinating opportunity to hear about. How big is it? What's it like? How's it worked out?
I'd have to ask for some help on that. It must be well over 10,000 units, and it's 5-story townhouses and condominiums along, and then on the edge, smaller units, townhouses, and a few single-family units on the outer edge.
And is it mixed use so that there are stores and schools and so on embedded within the community?
Yes, there's a main street through it and a Safeway that has structured parking, no surface parking. Above the Safeway are several stories of apartments, and it's other retail. So and that's concentrated in the core, and then everyone's within a good walk, short walk. Narrow streets, lots of intersections, and some green areas, common areas scattered throughout.
How about pricing? Is there affordable housing as part of it?
Yes, there is. Yeah.
So lots of interesting questions to come up there. You could ask the question of, do kids walk to school there more than they would in other parts of Montgomery County where you have less density, assuming that the schools are embedded in the communities? The affordable housing piece of it is very interesting. It turns out that some of the people who are least able to live near where they work and to enjoy short commutes are people at the bottom of the socioeconomic ladder. So I don't know much about the neighborhoods here, but where I live in Atlanta, the people who can live near the Emory campus and who go to work at Emory are the faculty, the physicians, and so on, some of the nurses. But the people who work in the hospital laundry and the people who work in the hospital cafeteria typically have to live 5, 10, 15 miles away and commute by car. And their cars are the cars that we'd really like to see driving less because they're an older generation of cars and they're typically more polluting. So very interesting to look at a situation like the one you're describing where affordable housing was built into it. You mentioned apartments up above the supermarket. So one wonders whether the people who work at the supermarket have shorter commute times than the people who work in supermarkets in more conventional suburban communities. And if so, that'd be a very interesting fact to document. It would mean that that's a greener form of development, especially for that particular stratum of our society. And it also might mean that life is healthier for people like that, because it may mean that they walk to work instead of drive to work. So just 2 thoughts about the research opportunity that lies there.
Maybe you could talk a little bit about health impact assessment and how to make the research into a productive policy decisions that are not ad hoc. We know what good is, everyone in this room, but to get it implemented, it's done piecemeal and with arguments that aren't structured about the consequences, the health consequences.
Well, thanks for that question. So health impact assessment, HIA, is actually a term of art. It's a standard, relatively well-defined practice. Those of you who have dealt with larger projects probably are familiar with environmental impact assessment, which is an EPA requirement, and a lot of people don't like it very much. It is the best intentioned practice you can imagine. The idea is before you carry out a project, study systematically what the environmental impact is going to be so that you can then minimize adverse impacts. Health impact assessment is different in that it's not a regulatory requirement, although there are those who argue that health impact assessment should properly be included in required EIAs. But in general, health impact assessment is a voluntary activity undertaken by health departments or academics where they'll look at a policy decision or a set of options, and they'll analyze systematically, generally not very quantitatively because data aren't generally available, but semi-quantitatively or qualitatively, what are likely to be the health impacts of various options. So, let's suppose that in your community, in Montgomery County, you've got some federal transportation money coming in. And one proposed use of the money is to widen the highway from 6 to 8 lanes, or a second option would be to use less of the money for highway improvements and build bicycle paths. And a third option is to build sidewalks in selected strategic parts of the county so that people could walk to school or to work. Well, you might analyze the health implications of each of those, and you would be systematic about it. So you would look at the expected number of car crashes that would result from the varying levels of automobile travel. You'd look at levels of physical activity. You'd look at air pollution contributions, a tough one to quantify because the incremental changes are relatively small. You'd look at impacts on water runoff and on stream quality and on drinking water quality downstream. Look at all of the impacts that plausibly would flow from those various policy decisions, generate conclusions about the health impact of each, and offer those to decision makers as they make the decision. So that's health impact assessment. Relatively well established in parts of Europe. A lot of it came out of the UK, and most Scottish development projects now are preceded by very impressive health impact assessments. And it's catching on here in a localized way so that some health departments, San Francisco is a good example, Anchorage is a good example, are doing health impact assessments routinely, but most jurisdictions aren't yet doing it. It's a very good tool and one that we're pushing very hard at CDC. We're hoping that more and more public health departments will take it on. That was the most long-winded answer to a simple question. Yes?
Two ideas for research. One, following us
on the King Farm project. There's another planned project that's a greenfields transit-oriented development project in this metro area, and it's Moorfield Station development in Loudoun County. I was the planner at the time that we reviewed that development application, approved it. Who knows when it will be built in this economy, but when it is going to be built, after it's built, there's some opportunity there. Also now I'm a researcher, a planner and researcher for AARP, and my planned research for 2010, once the National Household Travel Survey data is out, is to look at the effect of the built environment on the travel patterns of older adults. It would also be really fascinating to combine that with some health data, but being a planner, I'm really not that familiar with what's out there and how data sets might be able to be combined and if there's any possibility. So.
Well, boy, we sure could. We have used some of the National Household Travel Survey data at the CDC, and it yields fascinating insights. So, two examples. One is that when you study people who commute to work by transit, and it's not a large number of Americans, but there's a substantial number, it turns out that commuting to work by transit means that you undertake physical activity routinely. You walk from your trip origin to the transit station. And then at the other end of the trip, you walk from the transit station to your trip destination. And then you do it in reverse at the end of the day. Fully a third of transit commuters get a half hour of physical activity per day, which is the CDC recommendation, simply by being transit users. So there's a nice, simple question that you could ask, and we did, of the National Household Travel Survey data. We also studied something a little more complex and probably iffy, but we looked at the question of whether social capital is enhanced based on some modes of travel as opposed to others. And it turned out that in communities where travel distances are longer, that social capital, as indicated by purposes of trips, seems to have been decreased, so that more trips are made. In the NHTS, people specify the reason for a trip. And it can be helping a friend, it can be going to a civic association, and so on. A larger proportion of trips are made for those reasons that presumably reflect high social capital than is the case in more sprawling suburban areas. So, great opportunity for research. We at CDC do work with AARP on doing some of these kinds of things, and I'd love to talk with you more about that. Getting back to the first thing you mentioned, it's called Warfield?
Warfield Station.
In Loudoun County. What do you see as the research opportunities there? What's going to be special about the place, and what would you want to study?
It's very similar to King Farm, and so the research opportunities talked about there can also apply. But you could also do the before and after if you're able to capture people,
Right.
similar to the Atlantic Station.
Right. Great.
Another subject that might be of interest, the military is redoing its housing systems across the country, called Residential Community Initiative. The concept is, instead of the federal government building and owning housing for its soldiers on military posts, is housing is being built by a regular housing developer, and then a soldier's what they would get for living off post. That automatically goes to the developer in the form of rent. A number of installations have applied traditional urban development type standards in the way they've built their housing. Fort Belvoir on the south side of D.C. is a classic example. They have essentially a downtown street with retail on the first floor and two-story townhouses on the second. That is the single highest demand place to live on Fort Belvoir, much to people's surprise, with a Kentland-style mixed-use, relatively high-density, very grid-type network street that creates a very highly walkable community. Fort Lewis, Washington is going to be doing much the same. And there you have a controlled population and a controlled setting, and I think that might be a very valid condition for applying some research to apply urban planning and public health.
That's fascinating. I know very little about this issue, but I take it from the newspapers that military families are under considerable stress at times in terms of absences of the active duty members and other factors. It'd be very interesting to see whether living in more of a new urbanist or traditional neighborhood development context is better for the family dynamic than living in a more
Loop and lollipop type.
Yeah.
I was at Fort Belvoir last weekend and encountered a housewife walking her child and a dog, and I talked to her. She says, when the kids get home from the school bus, it is just a hub of child activity, literally until after dark. And she said, based on the evidence I had talked with this one lady, the social networking among her neighbors was stronger there than in where she had lived in military housing before, which was more of the traditional urban sprawlish type development.
Well, you could even hypothesize, you want to think about this, but given that it's a closed system socially with its own healthcare system, you can actually quantify how much healthcare seeking people engage in when they're military. You could hypothesize that the stronger social ties that may exist in this configuration lead to more resilient people and to less need for seeking health care. You could look at medication use, or you could look at clinic visits as an outcome. I have no idea whether this is a possibility to do. You'd want to look at literature to see whether it's even a plausible hypothesis, but this is the kind of thing. Wouldn't it be fascinating to know that certain kinds of community developments lead to lower healthcare costs for whatever reasons, either the stronger social ties or the more physical activity or whatever it is? But that'd be
A colleague of mine involved in the Army Medical Department told me in one recent fiscal year, the Army DOD spent $2 billion dealing with health care associated with lifestyle choices: alcohol, tobacco, and obesity. Obesity, health care related to obesity and associated illnesses consume more than half of $2.1 billion budget.
It's especially impressive given that the military has physical fitness requirements, and so a lot of the people who are in the population are not likely to be obese, and that means that the obesity is concentrated among probably spouses and kids, and it's an especially impressive figure given that. Other comments? Other research inspirations?
I had a question before you started your presentation about health department.
Well, here comes the microphone.
This may not be your area of expertise, but I had this question written down before you started. It's about the use of gray water, using water from a washing machine or a dishwasher for landscaping purposes. The state of Maryland doesn't allow that. The health department won't. You can do it illegally, but you can't get approval to do that. But I was just wondering if, does somebody at CDC quantify whether or not states that do allow the reuse of gray water has higher diseases?
I don't know the answer to that. It's a great question.
It is a good question.
Yeah, questions. There's a whole series of questions that have been raised like that. I remember one came in a few weeks ago challenging CDC because we've got on our website, apparently, it's a different part of CDC than mine, but evidently somewhere on the CDC website, it advises using dryers that reach a certain temperature to effectively disinfect clothing. Well, it turns out there's probably not a shred of evidence that dryers at a certain temperature disinfect clothing. But it's energy intensive, and for those who are interested in encouraging clotheslines instead of the use of electric dryers or gas dryers, they'd like us to withdraw that recommendation. So there's a team that's re-examining that as well. So a lot of our traditional uses of water in ways of carrying out household chores seem to have health thinking behind them, but we don't always have the evidence base. It's a very good point. I'm actually going to go back and look at that. I don't know if CDC makes recommendations about gray water use, but if not, we ought to be looking into it.
So we look for that on one of your email responses, maybe?
If somebody emails me that, it'll be a sure thing that I'll have to get to it. I won't forget it. Thank you.
Yes, I'd like to push back a little bit on your first comment about planners and public health being evidence-based. I'm in the process of putting together my dissertation proposal at University of Maryland, and the evidence requirement is pretty steep.
Yeah. You're a very good program.
But thanks.
Yeah.
But I think planners are split into two camps, and there is a camp that kind of looks at things like a school in the middle of nowhere and says it's just common sense. We ought to go ahead and do something. So there isn't the big push to do all the evidence and the studies. It's just common sense. Go ahead and do it. And then there is the camp that is based pretty strongly in social science research methods, and in that group, evidence is a big deal.
But I take your point. It's a very good point, and I was a little sweeping in the statement that I made to make a point. There's also another way of pushing back, which is, do we always really need evidence? And sometimes things are obvious, and you don't want to hold up making decisions and implementing based on the need for research. But that's a tricky decision to make because things that seem to be common sense don't always turn out to be right. And we have a long and checkered history in healthcare of using medications or surgical procedures because obviously they work, and then when they're tested, they don't work. But that said, there are cases where you really don't want to linger and ask for more evidence. You know enough to go ahead and act. So those planners who say it's common sense, let's not bother amassing evidence, let's just do it, probably are right sometimes. Part of the wisdom is to know when you need research and when you don't.
One other comment. I've had occasion to look at the public health indicators that CDC has published, and one of the things that kind of frustrated me in that whole process is that it seems like planners and public health officials work kind of at different scales. The indicators are great, but they don't work at the scale that planners work at. And And so there's I love the cartoon you had up there. I think that's very appropriate. And I'm trying to figure out how to bridge the gap a little bit better. And I don't know if there's any way that those indicators can be at a finer scale or not.
How would you characterize the scale difference? You mean that public health data are on the county level or the census tract level are bigger and planners work at the project scale?
Yeah, county or, they tend to be county or larger, and we work at smaller scales.
Yeah, no, it's a problem. It's especially a problem that stymies us in terms of health data because there's such an emphasis on privacy. So if you downscale your health data, then there's an increasing risk of violating confidentiality in the data. That's just an inherent tension about using health data. We just need to be creative and figure out opportunities to get past that. And I think some of the examples that I showed you here exemplify that we can actually get past those problems. But it is a real barrier. We need to respect privacy. And we can't identify data or come close to identifying data when it's health data. So that's just one of the ground rules of doing health research.
Are there any efforts in seeing what other countries, or even such as in Europe, what kind of efforts they have in the research field? I understand that for instance, in Germany, you can't design offices without providing natural light. That's a requirement. And I'm wondering if this is an example of effects of previous research and how they're being implemented.
I'm familiar with some. I think there are probably others who know a lot more about it than I do. One of the really nice papers that a lot of us quote a lot is by a transportation engineer, John Pucher, at Rutgers, who looked at German, Dutch, and American transportation modes and looked at crash fatalities as the result. It turns out that the background for this is that pedestrian fatalities have been declining pretty steadily here in the States for several decades, and that's good news. We don't want pedestrians to get hit and killed. But the reason for that decline is that fewer and fewer people are out there walking and biking. So it looks as though there may be this trade-off that we would like not to have to make. Do you protect pedestrians by eliminating them from walking? The European data shows that it's not an inherent trade-off. In both Holland and Germany, you have far higher rates of walking and bicycling in cities and far lower rates of pedestrian and bicyclist fatalities in those same cities. And it turns out probably to be a question of infrastructure and of acclimation, if you will, that drivers and pedestrians and bicyclists are all accustomed to getting along with each other. So it's a nice example of where health data and built environment data, travel data in this case, when compared internationally, do give you very good insights. I'm aware of some of the Northern European regulations requiring daylighting in buildings. There's actually a pretty good evidence base showing the values of daylighting. And putting aside demonstrable health benefits, people like natural daylighting in their workplace, and performance seems to be enhanced by natural daylighting too. But that's a feature of building codes that I don't think has come over here yet. It's nice to compare the different national practices because it helps us be aspirational.
We've got time for a few more questions.
There's one right behind you there, too.
Hi, I guess just to play devil's advocate for a minute, we have a lot of evidence, in terms of obesity, asthma, that sort of thing, that the way that we've developed the last several decades is not healthy. And if we have that evidence now that we know that we're doing something wrong, and we continue to perpetuate those development patterns, then how is having evidence of healthy green communities going to change the way that we develop?
Great question. It goes back to the issue of do you really need research? So let me turn the question around and ask you, okay, suppose you were the building czar, the urban planning czar. Knowing everything we know now, what would you do to control the obesity epidemic?
Well,
do we know enough to know what to do?
I guess that I'm coming at it from sort of biased perspective because I do work in an urban setting, and so when we look at projects, we're looking at walkability and sidewalks and that sort of thing, and designing the streetscape so that it encourages walkability. So I guess I'm sort of biased in that I would say that we need to be developing, in closer proximity to public transportation and encouraging people to get out and walk and have daily exercise so that we're not facing this obesity epidemic.
So let me say, I'll play devil's advocate to your devil's advocate.
Okay.
And I'm a developer, and I'm looking to use my money wisely. I want to do the right thing. But if you're the regulator, I want you to tell me, do I need to put sidewalks on both sides of the street or just one side? Does it make a difference in people's walking habits? How far does a house have to be from a transit stop before people won't walk the distance? What's that number so I can build to it? I can go on and on. But how close do schools have to be to houses for kids to walk? What level of sidewalk quality do we need to get kids to walk to school? Is it worth it to zone out fast food restaurants from within a half mile of every school? It's going to be a political struggle to do it. Should we fight that fight? Do we have evidence that if you clear out the fast food restaurants from near schools, kids' weight goes down? There actually is some evidence emerging to suggest that. But these are, I think in general terms, we probably would all agree on the principles that we think are going to be healthy. I think a lot of the details remain to be learned, and that would be the role for research. But I'd have to agree with you on the big question. Let's not do research where we know enough to act, but let's do research where we don't know enough to act. Or, and this is interesting, part of the role of research is to generate new knowledge, like what distance is right. Part of the role of research is to document to decision makers in particular places that they've got a problem where they are so that they'll pay attention. I can't tell you for how many years we at the CDC funded research on the dangers of lead poisoning from air pollution in developing nations around the world because the Mexican Senate wasn't going to pass a law getting lead out of gasoline until they knew that Mexican children were suffering from lead poisoning. It didn't matter to them that we had data that English children and American children and Brazilian children will. So replicating the research locally is a policy driver. And that may be a second reason to do research.
One last question.
Thanks. My understanding is that there's a fair amount of research now about this, the topic of how views of nature and so forth aid in patient recovery. To what extent is that making its way into the design of hospitals or other healthcare settings?
There is this movement of green healthcare institutions that I think is taking off, partially based on evidence, partially it's environmentally driven, partially it's the result of leadership in the health sector by big organizations such as Kaiser. What's interesting is it's one of the areas where what's green and what's healthy can collide with each other. They aren't necessarily the same. So, for example, we know that infection control is more effective when patients are in single rooms. But you need many more rooms than if you put people in double rooms. So you use more space and you use more resources if everybody's in a single room. Having those big windows with natural daylighting is great for patient recovery, but it's more resource intensive because you use more energy, all things being equal, to heat and cool the building than would with smaller windows. So it's one of those areas where there is a trade-off of different goals and you have to optimize both of them together. That said, I think that this green healthcare movement really is taking off and proceeding well. And one of the nice things is that healthcare facilities are one kind of facility that's getting built now quite a bit. If you move from this country overseas, we had the question on international comparisons before. The British National Health Service has made a commitment to building all of its facilities as green facilities. And, of course, what that means operationally may differ a little bit from place to place. But it does mean energy efficiency. It means using lots of natural daylighting. It means using natural materials in the construction. And there are many ways in which the environmental goals and the health goals coincide there. So we may end up taking a lesson from British construction practices.
Well, this has been a really interesting presentation tonight. Thank you very much. And we've had some really terrific questions. And I'd like to remind everyone that we'll be taking your questions online over the next few weeks and then submit them to Dr. Frumkin, who has kindly agreed to answer them, and we'll be posting those responses. So there was a sheet left on the chairs next to you giving you directions on how to submit those questions. We hope you will join us in this conversation online. And again, thank you, Dr. Frumkin.
Thank you all.